Hi, my name is Kirk Hamilton, your host of the Staying Healthy Today show. And this is a show where we talk to individuals, professionals that have expertise in certain areas about individual health and world health. So today I have a special guest, someone I'm going to ask about anesthesia because I have had some experiences over the last year, uh, two in particular, that I've gone under. It's always good to have tips from a health professional who knows what they're talking about to help you um, have a better experience. So I want to welcome Ken Childers on. Welcome, Ken. Thanks for
Thank you.
coming. Um, so I wanted to ask, first of all, Ken, what is your background and how did you get into doing anesthesia?
I've been in healthcare for 25 years. I started off as a medical laboratory technician with the 187th Fighter Wing at Danley Field, Montgomery, Alabama. And then I went into the National Guard with the 187th in order to increase my chances of getting into nursing school. And then I went to nursing school and graduated in 1999 and went straight into working in the ICU. And then from there, I decided I wanted to leave Alabama. So in 2001, I moved to San Francisco and worked in some high-level ICUs. And then 2006, 2007, I started the application process and finally was accepted in 2008 into Samuel Merritt University in Oakland. And I matriculated from there in 2010, and I've been working since 2011 as a CRNA.
What is a CRNA? Because many people still don't know. I'm a PA and I have to explain what I am. And a CRNA practices medicine, and so they'll say, well, what's the difference between an anesthesiologist and a CRNA? I probably get that 7,000 times.
Well, actually, CRNAs don't practice medicine. We actually practice the act of nursing. And that was decided upon in a court case where our anesthesiologist colleagues tried to curtail our ability to work. So there's three different professions available that can provide anesthesia. One is CRNA, Certified Registered Nurse Anesthetist. We are the oldest practitioners of anesthesia as a dedicated specialty. Anesthesiologists came after us. CRNAs were utilized in the Civil War. And dentists can get an anesthesia certificate, and that is because the discovery of anesthesia, or the roots of modern anesthesia as we know it. Anesthesia actually goes all the way back to the Sumerians with their use of morphine, but modern anesthesia was actually developed by dentists. It was a dentist who first recognized the use of ether and put it into practice.
Wow, I didn't know that. That is the oldest. So the oldest profession is the nurse doing anesthesia.
Yeah,
Is that
well,
what you're saying?
originally, so what happened is as ether came into practice, and it was basically very very low level stuff. They had a breathing mask. Initially, what they would do is they would delegate the administration of anesthesia to the lowest ranking person on the surgical team. So you would have modern days, it would be the attending and the fellow, and then the, say, third year resident, second year resident, and first year resident, all there to do an appendectomy, right? So what they would do is they would take the first year resident and they would say, okay, you do the anesthesia. You'll be up at the head, with the drape up. And so they would be more interested in looking over the drape and seeing the technique of the procedure. And oftentimes they killed the patient by overdosing them with anesthetic. So, and this is before monitors or anything like that. So they decided what they would do is delegate it to a nurse, and they would have the nurses sit at the head behind the drape, and they would watch for respirations, skin pallor. They would look at the color of the lips, and monitor for any reactivity. And so they were the first person to actually sit at the head and dedicate only their attention just to the patient. And they found that by doing that, the survivability of the surgery and the anesthetic itself, the rates were greatly improved. So women were actually the first CRNAs, nuns.
So when did the anesthesiologist get the hint that they better focus
Well,
more?
Anesthesia,
so to speak.
anesthesia is a dedicated anesthesia as a classically trained MD anesthesiologist, as we call it, came about closer to World War I. And that's when we had a lot more education. We had a lot of breakthroughs. We had more and more medications that were being developed specifically for anesthesia. And so then you had doctors who wanted to specialize in it. And so that's why even today, when I worked at Stanford, or if you go to a place like UCSF, these higher institutions of learning, the anesthesiologist there, what is the traditional role of the MD anesthesiologist, is actually in clinic and is doing clinical studies. So those people tend to, so your real MD anesthesiologists that are your pioneers are all going to be in kind of clinical studies. They're not so worried about the day-to-day, boots on the ground, doing the actual anesthetics themselves. They're more interested in doing cohort studies and post reviews and all this kind of stuff. So that's really where the MDA has kind of fit in over the years. But becoming a doctor, as we know, different specialties of doctor, because of the billing structures and the way that our financial remuneration of physicians has been over the years, became very lucrative to be an anesthesiologist. So it was not uncommon for these people to be, contracted with a group that serviced a hospital and make $500,000, $600,000, $700,000 a year. And it was just very lucrative. So you saw a lot of people go into anesthesia, just as we've seen, there's people who go into their fields of study for all kinds of reasons. It might be because they're genuinely interested in it, or they're just interested in the paycheck at the end of the day. In my opinion, what I've found, and this has just been my opinion over my 25 years in healthcare and my 14 years in doing anesthesia, is that CRNAs, you still have a subset of people who are really there for the paycheck, and they tend to be pretty obvious. But the nurse anesthetists tend to have a better bedside manner. They tend to have a little bit more concern for the patient. They tend to be a little bit more hard on themselves, definitely harder on each other than our anesthesiologist colleagues are. And so I think because of the different pathways, because one starts out, it's a minimum 2 years as a bedside ICU nurse. I had 8 years as doing bedside ICU or critical care. So you spend a lot more time with people who are really sick. You see them pre-surgery, post-surgery. You see a lot of people die, a lot of end-of-life care, things like that. It tends to change your focus a little bit more on the person. I maybe a little bit more of a holistic approach when you're seeing people, rather than being as clinical as some of our MDA colleagues tend to be, where it's very the matter of fact, this is what we're doing, this kind of thing. And I think that also kind of goes back to also the rigorous scientific method that's ingrained in them more in their schooling, especially because they have this more clinical research background and history.
That was a good review. I mean, that's a lot of stuff I didn't know, and I'm sure a lot of people listening didn't know. So let's get into what if you're telling your father-in-law how to have a good surgery, because he's going to go underneath for anywhere from an hour and a half to 2.5 hours. What should he be asking the anesthesiologist? Or I've had both CRNAs and anesthesiologists. What do you ask?
I mean, I'll flip this back around on you a little bit. It's sometimes a little knowledge can be too much for some consumers. So some people want to know a lot, some people don't. What I will share with you is, what do I like to tell my patients prior to giving them anesthesia? What do I like my patients to know? Right. So if I have a patient that comes in that's completely uninformed, or if I have a patient that comes in that seems like they've got a degree from YouTube University, I tend to want to let people know, that I've been doing this for a while. Even when I was a new graduate, and I was fresh out of school, I'd still tell people I've been doing this for a while, because I have been. It's a 24-month program or 27-month program when I went through. It's 34-month program now. But you've been doing a lot of clinical, so you've been doing it. I like to let people know that I've been doing it for a while. If I can speak to the time that how long I've been working with the surgeons, I always like to bring that up. I think that's something good to know. I like to tell my patients, I've been At 7x7, I've been with these guys, with Dr. Scharf and Dr. Duncan and their colleagues. I've been servicing them for almost 11 years now. And so I've got a good idea of what they're going to need at any given time during the surgery. And I've got a good concept and a good grasp of what the surgery entails and what points of the surgery are more important for me to have you deeper, and what points of the surgery is it okay for you to be a little bit lighter. So that knowing, being able to be reassured, knowing that your anesthesia provider is familiar with your surgeon and that they have a good background together, they have good teamwork. That's always important. I like to explain a lot about what the patient's experience is going to be. I like to tell patients that it's not going to be refreshing, such as them being asleep. It's going to be more like time travel. So once I get the small IV in, which will cause a little discomfort, but it won't be very much, and it'll be over very quickly. Soon after that, they're just going to be time traveling, and they're not going to remember anything, and they're not going to have any knowledge of anything happening until everything's done. And when they wake up, a lot of patients wake up and they say, "Are we going to do this?" Because they have no recollection of having the procedure itself. So, and that's my goal. And probably 75, 80% of the time I achieve that goal. The other 20% of the time, my patients just die. Just kidding. No, some people, everybody.
I didn't have a follow-up question to that one.
Some of the people do better than others, and some people are more relaxed than others when they come in, and then some people wake up and they're, like a scalded cat, right out of the gate. So everybody's personality is different. But for the most part, if you give people some expectations and you give them a realistic point of view and share with them what is a realistic outcome, it tends to do that. It tends to happen for them. And there's a lot of power in the mind as far as what I've been, what I've noticed over maybe the last 5, 6, 7 years of my career. Now that I'm in a different place in my career than obviously when you first graduate, you're just fixated on, oh, I want their blood pressure to be this. I want their heart rate to be this. I want this to happen. And you're everything's very tight, and you're looking around, you're focused on this. You're focused on this. You have kind of a telescopic point of view. I've gotten to a point now where I can just kind of get an overall feel of what's going on in the case at any given time. But now I've started working a lot more in the last few years on my pre-op phase in talking to people the way that I do, but also the power of suggestion is very, very strong. And so working on putting suggestions in people's heads, winning their confidence, getting them relaxed on a personal level, and then making suggestions to them as they're going unconscious that are positive reinforcements, that when they wake up, you can see that there's a psychological effect there.
Let's move from there. And I think, how do you, maybe you already said this, but warn the patient when they wake up, they could be in a lot of pain. I mean, if a surgery causes a certain amount of pain, you probably told them how you're going to try and keep that down beforehand. Like you did with me, you said this, this block might work better than that block. But to me, that's one of the biggest things, waking up and,
yeah. In this day and age, honestly, if you've got people waking up in a lot of pain, then either you're doing something wrong or a member of your team is doing something wrong. I have been put in situations with orthopedic surgeons, for instance. I worked with this one orthopedic surgeon who, good at doing the orthopedic portion, at, repairing bones and lining things up and getting screws to go in and things like that. But the guy was against doing peripheral nerve blocks, and the guy was against putting local anesthetic into his wounds. And these patients would wake up and they would be in a lot of pain. And so for me, what recourse could I do? Well, they're under general anesthetic because that's all he wanted. And so, I would give them as much narcotic load as I possibly could. And then just to where that, they're breathing 12 times a minute, 14 times a minute, which you're going to have a prolonged wake up because you've still got anesthesia gas on board that they have to exhale as well. But there's tricks to getting that off. But then I would write very generous orders in the PACU. But I no longer work with that guy. He was one piece of many pieces of the puzzle or pie that caused me to not like that system and not want to go back to that system.
Mhm.
So that being said, I tend to not work with those type people. But there's honestly, with the technology that we have and all the availability that we have, people should not be waking up in excruciating pain from procedures. The only procedure that I can think of that I've ever done where there was nothing that you could do for the patient is we would take patients into the neuro room at Stanford, and we would do these facial cranial nerve ablations. And it was for, I think what the common name is tic douloureux, trigeminal nerve neuralgia. And those people, we would put them under heavy sedation, and they would basically, they would strap their head down, put them under heavy sedation, and then they would run a needle in, a CT guided needle. Actually, it wasn't CT guided, it was fluoroscopy guided needle. And they would get that needle tip right at where the nerve is. And we needed them to wake back up so that we could determine if the nerve was in the right place. And then they would burn the nerve while they were awake. And people would scream. I mean, it was awful. Like it was awful. That's the only thing that I've ever done but otherwise,
were they told that was going to happen? That they're going to?
Yeah. They were told that it was going to hurt. Yeah. But the neuralgia pain that they lived with constantly,
right?
If it could be defeated and they only had to go through, I don't know, 2 minutes, 3 minutes of, excruciating pain, but then get to this other side where, they were willing to do it. So, yeah. Yeah.
All right. Well, let's close this up. Give 2 or 3 tips to a new CRNA who wants to get work. What can they do? Or what shouldn't they do?
Well, the first thing you shouldn't do is job hop. Whatever your first job is, even if you hate it, if you get hired somewhere and you hate it, it doesn't matter. You need to stay there more than 2 years. Suck it up and just live with it. Live with the consequences of what you asked for.
Because why?
You don't want to see a bunch of changes early on in somebody's career on their resume.
Got it.
That's a red flag. I've gotten resumes. I've been through the hiring process at different places and looked at resumes. And one of the big things that sometimes you'll see things that are just, it's like incredible. It's like somebody started working at a hospital and within 4 months they were the chief CRNA, and then they've only been there 8 months and they're already looking to move somewhere else. It's like, what's going on with this person? Or, they've got 8 months here, 12 months here, 4 months here, 6 months here. They're bouncing all over the place. And it wasn't travel contracts. It was actual employment agreements, where they came in and they were set up as an employee with all the benefits and everything else and all that kind of stuff. So that's the biggest red flag, for me, is looking at people's CVs and seeing that they bounce around. Even if you hate some place, if you stay there 2 or 3 years, it at least shows that you can go along to get along, and that's what most people want to see. But yeah, otherwise I wouldn't chase money. I would chase the experience. I would look for opportunities that are going to, allow me to practice to the fullest extent. And, give me the most responsibility and give me the most options for a variety of things of work to do. And I guess 3 things. The other thing would probably be I would not get neck tattoos or big piercings or anything that, don't get dreadlocks or anything that is unprofessional or unbecoming, especially in your early days, because it's just until you've built some level of confidence or had life experiences, you don't really need to start doing that kind of stuff to make yourself stand out. You really want to blend in more than stand out.
That's a great way to end. All right. Well, thank you, Ken, very much for taking the time out of your busy day. And I want to thank you, the audience, for listening to this edition of the Staying Healthy Today show. Until next time, stay and be well.